Okay. All right, so we'll finish up Paget's disease, then we'll take a break. All right, so Paget's disease. All right, so Paget's disease of the bone. Because those of you who came from OB, there's Paget's disease of the breast. We are not talking about that, right? That's usually due to breast cancer. So Paget's disease of the bone, or PDB, it's the second most common bone disease next to osteoporosis, right? 1 to 2% of white males, whereas osteoporosis was primarily it's more commonly in females, right? But it actually originated, it's usually white men from Lancaster, right? Or Lancaster, England, actually. These guys are highest risk for this disorder, right? So it can be genetic, but can also be due to other stimuli such as recent viruses and recent exposure to RSV, measles, etc. All right, those things could put you at high risk for Paget's disease, right? So basically what's going on in Paget's disease is there's increased bone metabolism. You have a whole bunch of osteoblast activity, a whole bunch of osteoclast activity, right? They're going haywire. They're going back and forth, back and forth, back and forth. So therefore, and eventually what you get is bone that is imperfect. Because remember, your body does not make things perfect again, right? So you can see the legs are bent, the face is distorted, right? So the bone has changed shape, right? In Paget's disease. Okay, so there's initial phase where you have all this clast activity where it's breaking down the bone, and the osteoblasts are trying to fix that at the same rate. And actually you can do scans, I think they're called thermography scans, where you can do a scan to see where the heat map is, and you can see all this extra activity in the skull, for instance, or all this extra activity in the hip or long bones. You can see all that activity because the osteoblasts, osteoclasts are going so fast, right? They're eating up collagen fibers. You can measure those collagen fibers in the bloodstream, and the osteoblasts are laying down all of that calcium phosphorus, and you can then get a rise in alkaline phosphatase. Right, alkaline phosphatase is used to lay down is what osteoblasts use, right, to weld the calcium phosphorus to the collagen matrix, right. So there's collagen fragments we can measure. CTX is the easy name because the long name is not easy, right? So C-terminal telepeptide of pyridinoline crosslinks, cool, right? But it's CTX is a little urine test or serum test we can do to see if they're breaking down collagen super quick, right? So we get deformities, which can be very troublesome, right? Not only their social appearance, but also we start blocking all these little holes. What's the fancy word for a hole in the skull? Foramen or foramina, right? So those foramina get narrowed, right? They get sclerosed or stenosed. They get narrowed, and because they got narrowed, those little nerves going through there, such as the cranial, vestibulocochlear nerve, which is cranial nerve 8, right? So which is for your hearing and balance, or for your eyes, your optic nerve, right? Your cranial nerve 2. That is because you have 2 eyes, right? So it's going to cause that. You can cause blindness. So you can cause hearing loss, right? Not only the facial pain from like occluding the other nerves. Okay. So we actually have a lot of heat, and we can actually have a lot of vasogenic activity, and we get lytic lesions like we get with what other disorder? Which other cancer we talked about last week has lytic lesions, where the bone gets lysed and broken apart? Hmm?
Oh, AL. Or no, the last one.
No, AML, ALL, CML, all those ones are causing more bone pain because you're producing more stuff in the bone. You're not breaking down the bone and causing CRAB, hypercalcemia, and BJ proteins. What's it called?
AML.
No, you got one of the letters. You got one of the letters correct. MM, multiple myeloma, right? Multiple myeloma also has lytic lesions, right? So yeah, so you're forming little band-aids to try to fix this increased breakdown, and those little band-aids are not going to survive long, and therefore you're going to get a suspected spam. All right, so I got a call. So you got this increased risk for fractures, right? And before, with osteoporosis, we called it fragility fractures. That's the only one that you see fragility fractures, but it really is a pathological fracture where you fracture because your bone is weak, right? So you're a high risk for pathological fractures with someone who has Paget's disease, right? So you got bone pain as well because your bone is constantly being dissolved and eaten. You got those collagen fragments going up. You get lytic bone lesions. We have skeletal deformities, and then alkaline phosphatase goes up. Okay, so here's symptoms. So there's this movie in the 70s that came out, and it's based on a real story. Someone who has this Paget's disease, where I think it was called the mask, right? So where you have a increased overgrowth of bone tissue, right? You can see this is a leg, right? So the leg becomes separated like that, right? So we have all this, let's make sure I got that right. So all these deformities that occur over time. Okay, so all these deformities, of course, are disfiguring, but the real problem is that we are high risk for fractures, right? So the fractures are a problem, and we could get pathological fractures that can develop. And also this increased activity, we're at high risk for, by high risk, it's like, well, less than 1%, well, that's still a high risk, right? So if there's 50 of us in here, that means one of us might get cancer, right? If we all had PDB. So it's a high risk of less than 1% for cancer or osteosarcoma, bone cancer, right? One of the types of bone cancers. All right, but pathological fractures, of course, are going to be even more debilitating. Okay, so diagnostic test, what are we going to do? We're going to do look to see if the alkaline phosphatase is going up, and ALK-PHOS or ALP is also elevated in what? In gallbladder situations, right? So how do you know it's not gallbladder? That's where you measure GGT, right? So GGT was one of our gallbladder labs. When GGT and ALK-PHOS are elevated, you got a gallbladder problem. If it's just ALK-PHOS, it could be gallbladder, but it also could be bone, right? So what else? Collagen breakdown, right? The osteoclast are cleaving bone left and right, so you can get those CTX fibers. You can measure that. Also, you can measure in the urine other collagen fragments. They're called the hydroxyprolines. Okay, there's collagen scraps from all the collagen breakdowns. So when you lay the collagen, you only lay the good part. The other parts you're gonna, just like when you're laying tile, which I've never done. But if you lay tile, I've seen on TikTok where you gotta cut it, and you gotta make sure it lies in place, and it's like really satisfying, right? But those little fragments, they're gonna be excreted, right? Or they're gonna be in the bloodstream. Okay, you should wear an N95 when you're cutting tile, I think, right? Anyways, you're gonna have a normal calcium because the osteoblast and osteoclast activity is actually matching each other. They don't actually, there's not like one better than the other. They're actually both functional. Okay, what else? Radiology findings, you can see heat maps of bones that are increased activity, right? So that's called thermography. And then they can do a bone scan also to look to see where there's hot spots and where those be Pagetic lesions or where Paget's disease is eating. All right, so here these lesions, you can see that it looks like a honeycomb appearance where it's eating out the bone. All right, there's really no real big treatment you can do. You can try giving bisphosphonates. That stops the whole process started with osteoclasts that were overactive, right? So we'll give bisphosphonates to try to fix it. For bone pain, we can give some NSAIDs, all right? And then calcitonin will tone it down. That will hopefully help decrease osteoclast activity and increase osteoblast activity to promote bone health. And then surgically, there's nothing we can really do, but if it gets to a point where it's like compressing a nerve, we might have to take put a little piece around it so that, or open up the stenotic area so we can actually improve function as much as possible. If they have an overactive piece, maybe they can take a little piece of the bone that's active. It might help, but it's not really going to cure the problem. Okay, so here's our foramina here as well. Different foramina, different holes that the nerves in the brain exit from, right, and go to a target area, whether it be the facial nerve, the ear, right, or the eyes for that matter. All right, so let's actually finish scoliosis and lower back pain. So we've got 2 slides on scoliosis. All right, so scoliosis is, again, an S shape in our spine. Okay, so we have this S shape, and there's different variations of it, but it's not a forward flexion, and it's not a hyperextension, right? Flexion was what? Kyphosis. I'm going to write that down here. Let me forget that. PH for flexion. Okay, so flexion, right? Whereas lordosis is usually lumbar actually also, but it's hyperextension, where their belly pops out because their spine is pushed out, right? So this is like lordosis, whereas here is kyphosis, right? But scoliosis is the S shape, right? So they all could present with back pain, but we're talking about scoliosis with the S shape, right? So it happens in women 5 times more than men. It's usually discovered at a young age, a school age, right? So you have a lateral and axial rotation. Axial means it's on its axis, it's spun to the left or right, right? So you can see how it is spun this way, right? So the whole, everything is shifted, right? So it's really unknown 90% of the time. We have no idea what caused it, right? But you can develop it if someone has a neuromuscular problem. They have muscles that are not strong. They have a neuromuscular disorder of some sort of muscular dystrophy, cerebral palsy or the like. They can then they don't have strong muscles to keep the rib cage where it needs to be or the spine where it needs to be. And there can be some congenital reasons where your vertebrae are not, they don't have the right symmetry. But usually it's idiopathic. 90% means idiopathic means what? Man, not 90% of the time you don't, but you can't really chart that and bill insurance for right. You have to say idiopathic scoliosis. Okay, so you have what's called a Cobb's angle. We'll talk about in the next slide. That's the angle of the curvature. How bad is their spine? Okay, so there's the test we do in school, right? And you can see the rib over here is much more prominent than the rib on the left. That means the ribs have been rotated, right? That one's much more prominent. And also it can be shifted up and down as well, okay, because of the S shape. And then it can lead to back pain. It can start pinching nerves and more advanced diseases. And when it starts having really starts having a lot more problems, that's when we can do surgery to fix it and try to align the spine, right? Technically, it's when a Cobb angle, I think, is greater than 50 degrees. Greater than 10 degrees is scoliosis, but when it's the angle is super, what's the word, obtuse? Or is that the right geometry term? I never took geometry. But if it's greater than 50 degrees, that is going to be a sign of needing surgery. It's going to start causing a lot more complications at that point. And you can see as we're churned to the side here, we're going to start having constriction of our lungs. We have restrictive lung disease, and it's going to put more stress on the heart. It can start causing problems. So it's important that we recognize it early. All right, so how do you recognize someone has scoliosis? Well, it could be obvious where you see the S shape, but officially an X-ray needs to be done. And the X-ray, we measure what's called the Cobb's angle. So you take the greatest curvature on one side and the greatest curvature on another side. Let's go put this away. Right? So, and you measure the angle in between it that intersects that. Right? It's not something you have to do on the test. It's just if it's greater than 10 degrees, that's a sign that you have scoliosis. Cobb's angle is scoliosis, right? It's not used for anything else, right? If it's greater than 50 degrees, that's where you start needing surgery, right? Before that, how do you know you have scoliosis? You can do an X-ray, right? And we mentioned also you have spinal cord instability at that point. But and then we mentioned the complications when you're very scoliotic. That's you get pulmonary compromise, you get the heart that can't work good, right? Because the lungs are so compressed. But this axial rotation will lead to other symptoms besides getting an X-ray, right? They can bend forward. You can see that one shoulder is higher than the other. You can see one iliac crest is higher than the other, right? You can see one shoulder blade is higher than the other. We mentioned that. One shoulder is higher than the other. These are signs that we have a scoliosis presentation, right? So shoulder blade, shoulders, rib hump, we circled on the previous slide. And then the Adams forward bend test. That's where they bend over and they lean forward, and you can see if they have that if one side is not is uneven. Okay, and they get pain especially with higher degrees of Cobb. And then the other piece is if it's less than 50 degrees, what can you do? There's physical therapy. There's things you gently get the spine in motion. Thermal hot packs can help. What else can we do? We can do a orthotic device. That's if their shoulders are uneven, we can give them a orthosis device or orthotic device. That's where it goes in the feet, right? For your orthos. What's another good word to connect that concept? But anyways, you have orthotic devices, right? Dr. Scholl's, right? You put them in your feet to keep get your spine in alignment, or get your hips in alignment, and thus your spine in alignment, right? And then if that doesn't work, we can use what are called TLSOs, the thoracic lumbar spinal orthotics. These are going to keep the spine in as much alignment as we can. And if we need to, we might have to get surgery, because usually greater than 50 degrees when you're using these, and that's usually surgery might be needed. So this is usually going to help prevent the need for pain meds, hopefully. Okay. So when they do that Adams 4 bend test, they also use this little scoliometer. It was only used to meter scoliosis, right? So scoliosis can be measured to see if there's unevenness. Okay, so that's scoliosis, and of course the surgical fix is they have to get pins and screws all up and down their spine to get their spine in alignment. Okay, so what would I have here? My cursor go? I lost my cursor. There it is.
All right, today we're going to use gym class to test you for scoliosis.
What is scoliosis?
I will not explain that. Nurse DeCesare, who's only ever treated you guys for headaches, is going to take you to the bathroom stall, have you take your shirts off, and then if she does find scoliosis, that's on you to tell your parents.
If they find out we have it, what do we do?
Yeah, is there any follow-up?
Nope. No, you're never going to hear anything about this ever again.
Why doesn't our doctor do this?
Only school nurses are qualified to check for scoliosis.
I feel like my doctor could easily take 30 seconds out of my physical and check for a curve.
This is the one thing that school nurses have. Let's let them have this. And then once you're done being checked for your potentially debilitating spine disorder, we will resume our archer unit.
Now, Ben, you got it.
What's that mean for me?